Okay, next question. Going on to question 4 now. Okay, question 5. Next question. This is a quick one, so I'll just give you like 30 seconds. Okay, hopefully that was long enough. Question 7. Going on to question 8, so just over halfway through them now. And this is another short one, so I'll just give you a few more seconds. Okay. Question 9. Going on to question 10. Okay, and now question 11. Okay, moving on to question 12. Question 13. Question 14. Okay, and going on to the last question, and then we'll go through the answers. Okay, hopefully you've all had enough time to answer all of those questions. For those of you that joined midway through, welcome to this Thursday 15 talk on neurology, which is going to be mainly...
Casey, I think you're on mute, or is that just me?
Can anyone hear me?
Yeah, I can now.
Oh, sorry, fine. So yeah, for those of you who joined midway through, I don't know if you missed that, but I'll say again, welcome to this Thursday 15 session on neurology, which will focus on headaches and hopefully cover a lot of different pathologies. Hopefully you noted down your answers to the questions as we were going through them there in exam conditions. We'll go through all 15 of them now. So when I put them back up on the screen, I'll start like a poll, and if you can all answer the poll, and then I'll be able to see if it was too easy. So the first question is, a 23-year-old lady is suffering from headaches. They occur every 2 to 3 weeks with no preceding symptoms or signs. She describes a unilateral pulsating pain exacerbated by movement or brushing her hair. Her headaches are associated with vomiting. Neurological examination is unremarkable. What is the single most likely diagnosis? Is that poll coming up for everyone? I've pressed. Yeah, there we go. Hopefully that should be coming into view. So what's the single most likely diagnosis? I'll just give everyone a couple of seconds to kind of pop their answer into that. It looks like quite a few of you already have, so I might just end it there. So can everyone see the results? So most of you went for B, but quite a lot of you went for E as well, which is understandable because there was a bit of a distractor in there, but we can go through the answer now. So the answer to this question is migraine. The key bits in the stem for that is because she's described a unilateral pulsating pain exacerbated by movement and brushing her hair. Is associated with vomiting, but her neuro exam was normal. So in terms of the other answers, so for A, meningitis, there's no suggestion in the stem that she has an infection, and there's no signs of meningism, so she's got no stiff neck, no photophobia in the question. So B is the correct answer, but C, cluster headaches, generally the pain's unilateral and around the eye, and it's described as a stabbing pain. And you'd also have like ipsilateral, so same-sided autonomic signs, so things like a red eye, a watery eye, and other stuff, but we'll go through that later on. Tension headaches aren't normally as disabling as is described in this question, and they're not normally associated with vomiting or exacerbated by movement and things like that. And giant cell arteritis, which is the other one that quite a lot of you went for this question. So the things that would make you think that, obviously, it's a unilateral pulsating pain and the fact that she's brushing her hair. The reasons that it's not that is because of things like vomiting, and given her age, she's only 23, so it would be really uncommon for someone of 23 to get GCA. It's more common in people who are over 50 years old. And the brushing the hair thing, so that's quite common in migraines in terms of you get increased sensitivity to pain, so it's called allodynia. So you can get that pain brushing your hair with migraines and GCA, so don't be fooled. They can all sound quite similar and there's no exact science to distinguishing between them, but make sure you're looking at the patient factors and the other things that they're describing that don't quite fit with GCA. So just to talk quickly about migraines. Oh, has that poll come back up for everyone? I don't know why. I'll just shut it if it's just for me. Anyway, so the key features of migraines are things like unilateral throbbing pain that's disproportionately disabling, photophobia, phonophobia, so that's to noise, allodynia, like I said, increased sensitivity to pain. You also can get nausea and vomiting with migraines, and 1/3 of them come with aura. So auras can be visual or sensory. So they can be things like tingling and numbness, or a scotoma, which is like transient visual loss, and things like dysphasia even. So you can get like stroke mimics, which are just auras for migraines. But the majority of migraines are without aura. You can have something called a prodrome and a postdrome for a migraine. So 2 to 3 days before, you might feel a bit more run down, a bit more tired than usual, and then you'll get a migraine. So it's not an aura, but you know that one's coming. The triggers, so you can remember them with this acronym chocolate. I won't go through them all, but you'll get the slides after. So you can have a look at them in your own time, but it's basically all the good stuff that triggers a migraine. And so diagnosis within the NICE guidelines for without aura, they have to have had at least 5 attacks that fulfill certain criteria. So it has to be things like unilateral, pulsating, moderate or severe, aggravated by daily activities. Basically a lot of these key features that we've already described. And then with aura, the threshold's just a bit lower in terms of the number of attacks that you have to diagnose it, because an aura is more kind of, it makes it more of an obvious diagnosis. Migraines can also be related to things like periods and menstruation. So there are separate treatment options for if your migraines are associated with your period. So you can give different types of triptans. So they're called like frovatriptan and zolmitriptan, that you can give a couple of days before your period until 2 to 3 days afterwards. So that's just like a unique treatment for if your migraines are associated with your period. But you've got to remember, a key thing to remember, especially for your finals, is that migraines with aura is a contraindication for the combined bill. So just like and a PSA tip as well, given that that's coming up. So red flags in migraine are things like an atypical aura, so things like motor weakness, double vision, poor balance. An aura without a migraine could be concerning for a stroke, so bear those things in mind. Sudden or severe onset, could it be subarachnoid hemorrhage? If a migraine's worse on standing, think about things like CSF leak. And if it's worse on lying down, worry about things like raised intracranial pressure. Recent trauma is a red flag for migraines. So could it actually be an intracranial bleed? And having symptoms of infection. So is it more likely meningitis? So just look out for those overlaps. And there's just a little picture for you to summarize all that we've talked about for migraines. So going on to question 2, I'll just start the poll for that one now. Hopefully you can all see that. Feel free to fill in your answers. So this one is: a 31-year-old pregnant woman presents to her GP. She suffers with monthly migraines and currently takes sumatriptan to manage her acute attacks. Her migraines are often stopping her from being able to work, so she would like to know more about prophylaxis. Her past medical history is significant for asthma and migraines, and her drug history is significant for sumatriptan, salbutamol, and paracetamol. So which of the following would be most suitable first-line option for migraine prophylaxis in this patient? A, topiramate, B, propranolol, C, amitriptyline, D, verapamil, or E, acupuncture. So I'll just share the results with you guys, a bit more of a mixed bag this time. Sorry if I made this question a bit hard. So most of you have gone for B, and then there's also A and C as well mixed in there, but it's kind of a broad spread. So we'll go on to look at the answer now. So the answer to this question is actually amitriptyline, and we can talk about why that is. So she's a pregnant woman and she has asthma, which contraindicates 2 of the medicines on the answer thing. So topiramate is actually teratogenic, so you can't give that in pregnancy. And propranolol is obviously a beta blocker, so you try and avoid that in asthma. You wouldn't want to give people, because it can cause flares of the asthma. So amitriptyline is the best option. Verapamil is prophylaxis for cluster headaches, not migraines, and acupuncture is recommended by NICE to help people with their migraines, but only if first-line drug prophylaxis fails. So you'd go for amitriptyline. In the acute phase, so treating migraines in the acute phase, simple analgesia is good, so like things like NSAIDs, but really what helps most is giving people things called triptans. So oral sumatriptan is first line, and you can offer the other types of triptans if treatment fails, or if they've got those migraines related to menstruation, so then you can give zolmitriptan or frovatriptan. And you can give these triptans intranasally or subcut if the patient's struggling with nausea and vomiting a lot from the migraine, they can't keep down the triptan. The antiemetics that are quite good to give for migraines are metoclopramide or prochlorperazine. You can give that buccally as well, so they don't have to swallow it. And domperidone, you can give PR. So if they are vomiting, it's another way that you can give it to avoid them having to take it orally. If they have a migraine with aura, then it's important to advise the patient to take the triptan at the start of the headache, not the start of the aura. And then in terms of prophylaxis, so there's not loads of options, but those main three, propranolol, topiramate, and amitriptyline. Just avoid topiramate with pregnancy and avoid it if people are on the pill. So generally in young women, you just avoid that one altogether, and you'd prefer to give them propranolol unless they had some other kind of contraindication, and then you maybe go for amitriptyline. And yeah, then acupuncture, riboflavin, that's just like a vitamin B2, but can apparently help reduce frequency. But just also bear in mind when you're treating people with migraines or answering questions about migraines, is there any clue in the question that it might be about medication overuse? And then is the answer maybe relating to like stop taking your paracetamol, stop taking ibuprofen, and see if that helps your headaches. So going on to question 3. So I'll share the poll for that one now. So a 48-year-old man presents to his GP reporting 7 episodes of severe disabling headaches over the last 3 weeks. The headaches last 30 minutes and are described as stabbing pains around his left eye. Which of the following symptoms or signs would best support the diagnosis of cluster headaches? So A, halos around lights, B, ophthalmoplegia, C, ipsilateral facial droop, D, swollen eyelid, or E, visual field defect. So have a look at your answers. You've all done really well on this one. So most of you have gone for D, which is the correct answer. So let's go through that. So he's a 48-year-old man with 7 episodes of severe disabling headaches. So these are really like key features of cluster headaches. They're more common in men and they're episodic. So lasting 30 minutes and stabbing pains around his eye. So A, halos around lights, that's a symptom that people get in glaucoma, like acute angle glaucoma. B, ophthalmoplegia is like paralysis of some of the eye muscles, stopping you moving your eyes certain ways. Whereas you don't get that in cluster headaches. You don't actually get any visual symptoms. You just get like a red, watery eye, and you can get eyelid edema, which is why the answer to this question is a swollen eyelid. Ipsilateral facial droop. So there's no signs of like nerve involvement in cluster headaches. You don't get any neurological deficits. And so the same with ipsilateral visual field defect. That wouldn't be correct either. So the answer is swollen eyelid for this one. And let's just go on to what they're like. So cluster headaches are a severe primary headache disorder. It's a recurrent and unilateral headache centered on the eye or the temporal region, and the attacks last from 15 to 180 minutes. And they're really, really disabling headaches. It sounds like just a really awful condition to have. So they're generally more common in males. So it's one of the rare kind of headache conditions that are more common in males. They're more common if you have a family history or if you're a heavy smoker, heavy alcohol user. And the onset is between 20 and 40 years old, typically. So in terms of this autonomic signs that you can get with cluster headaches, they are ipsilateral, so they're the same side as the pain. So you can get conjunctival injection, which basically just means red eye, lacrimation, so just crying, nasal congestion, just a stuffy nose, eyelid edema, so a swollen eyelid. Like all of these words are just fancy words for really simple things on the same side as pain. You can get miosis and ptosis, forehead and facial flushing and sweating, and a sensation of fullness in your ear as well. So kind of weird things that are autonomic related and associated with cluster headaches. So there's another little nice cartoon for you to summarize the different features of cluster headaches and the treatment as well. Just a quick run through the treatment of them then. So mainly avoid triggers. Triptans are used in cluster headaches, so subcut is most effective. I think they use subcut sumatriptan. Key things to remember if we're talking like getting bits in for your PSA next week. Triptans are contraindicated in people with coronary artery disease, peripheral vascular disease, or cerebrovascular disease, and they shouldn't be used in people who have very high blood pressure or really severe liver impairment, or things like that. Another treatment for cluster headaches is short bursts of oxygen therapy, so 100% oxygen. Apparently about like 70% of people get relief within 15 minutes of having some oxygen. It's obviously less convenient than just taking a tablet, but if it's effective at relieving this pain, then I would go for it. Preventative measures are things like verapamil or other calcium channel blockers. And then you go on to the specialist options. So these probably won't come up in your exam, but it's good to be aware that there's other things that you can do. So steroids, lithium, sodium valproate, and I can't pronounce that, galcanezumab is also an option for treating cluster headaches. You can try things like greater occipital nerve blocks, deep brain stimulation or trigeminal nerve compression, and those things might work for some people who are refractory to first line measures. Okay, so question 4. Let's try and share this one. All right. So a 30-year-old lawyer presents with frequent headaches occurring daily while at work, and lasting between 30 minutes and 2 hours. She describes the pain as dull and pressing, starting at her neck and spreading over both sides of her head. The headaches are worsened by loud noise and are not altered by position. Neurological examination is unremarkable. The patient is very anxious and convinced she has a brain tumour. Given the likely diagnosis, which of the following options represents the most appropriate and effective management plan? So A, advise simple analgesia and trigger avoidance and offer a prescription for sumatriptan and metoclopramide. Advise simple analgesia, trigger avoidance and regular exercise. Offer a prescription for topiramate. Request a CT head and refer to neurology, or prescribe carbamazepine and arrange follow-up in 2 weeks. Okay, so you've all smashed this one. So like 83% of you have gone for B, which is the right answer. So let's go through why. So she's a lawyer, sounds like a stressful job, occurring daily while at work, and they're lasting between 30 minutes and 2 hours. Is dull and pressing pain, which is bilateral. So she's got some phonophobia that she's describing, and she has no neurological signs. So A would be the treatment for a migraine, and B would be the treatment for what this lady has, which is a tension headache. Offering a prescription for topiramate wouldn't be appropriate given that she doesn't have any migraines. Requesting a CT head and referring to neurology. So I know that the patient's obviously very anxious that she might have a brain tumour, but what we're given in this stem isn't concerning. There are no red flags for that. So she's got no focal neurology and she's got no suggestion of any raised intracranial pressure. So it wouldn't be appropriate to ask for a CT head for this lady. Prescribing carbamazepine, so that's a treatment for trigeminal neuralgia, and she doesn't have any features that sound like that, so that pain would be like stabbing facial pain, and she's got a bilateral pressing headache. So just really quickly, we'll go over tension headaches. So it's the most common type of headache, bilateral pressing or tightening, mild to moderate, not associated with nausea, it's not really aggravated by physical activity. You might have some cranial tenderness when you palpate, and you might have some mild sensitivity to light or noise, but it's not like glaring photophobia or phonophobia as it would be in something like a migraine. So managing it is really straightforward, it's just simple analgesia, lifestyle advice. You can recommend acupuncture to people, CBT if it seems particularly related to stress and anxiety, or you can refer them if there's been no improvement or you've got some diagnostic uncertainty. And bear in mind medication overuse headaches, again, bear that in mind in all the like tension headaches and migraine and all headaches that come to you, bear in mind, is this person just taking lots and lots of paracetamol? So question 5. There's your poll. An 82-year-old lady is brought to hospital following a fall in her nursing home. Carers are concerned that she has become more confused in the last few months. The fall was witnessed and there was no head injury, but the patient is not oriented to place or time. She admits to not feeling herself and has put this down to poor sleep due to worsening nighttime headaches. Her headaches are global and most painful on waking. She's had no seizures. Her observations are stable. Her past medical history is significant for previous breast cancer diagnosed in 2004, for which she had a bilateral mastectomy and radiotherapy, osteoporosis, hypertension, recurrent UTIs, asthma, and falls. Examination reveals reduced power and sensory loss in the right upper and lower limbs. So what would be the most appropriate next investigation? A delirium screen, a lumbar puncture, nerve conduction studies, a CT head, or an urgent neurology review. So you've all done well again. D is the right answer here. So we'd want to get this lady a CT head quickly. And that is because we're concerned, given that she is having new falls. She's got new confusion that's happened over the last few months. She's not had any head injury, but she's confused. So we haven't really got a cause for this confusion. She's not feeling herself and she's having worsening nighttime headaches, which are most painful earlier in the morning. She's got a significant past medical history of cancer and she's got some neurological signs on examination. So this is quite worrying for something like brain metastases, just given her history of cancer. So we'd want to rule that out with a CT head. So A, bloods for delirium screen wouldn't be correct because she's got no signs or symptoms of infection. Yes, she's confused, but this confusion is months. It's not an acute delirium. It's not fluctuating. So it doesn't sound like a delirium. So we wouldn't do that. A lumbar puncture. So this lady's got symptoms of raised intracranial pressure, which contraindicates a lumbar puncture just because of the risk of herniation. If no other cause was found for her weakness and we'd ruled out brain mets, then maybe down the line nerve conduction studies, but it would be quite unusual for one nerve to give unilateral upper and lower limb weakness. So yeah, CT head was correct. An urgent neurology review would also be appropriate potentially, but the question asks for the most appropriate next investigation. So the best answer to that would be a CT head. So just going through differential diagnoses quickly of a raised intracranial pressure. So the features of that are things like obviously a headache that's worse on lying down, a headache that's worse on waking up, a headache that's worse on coughing, straining or bending over, associated with nausea and vomiting, and papilledema, so swelling of the optic disc, which there's a picture of just there, altered mental state, seizures, and some cranial nerve 3 and 6 palsies. So I don't know why. Oh yeah, there they are. So the top eye is an example of an oculomotor nerve palsy, so cranial nerve 3, and it's the classic down and out sign because cranial nerve 3 supplies all but the lateral rectus and superior oblique. So it goes down out to the lateral and it can't go up because the superior obliques. Sorry, I'm getting myself confused. And it's drawn down because so it's down and out because the lateral rectus and the superior oblique are the only muscles still working on that side. So that's why the eye is pulled down and out. And then cranial nerve 6 is an abducens nerve palsy. So inability to abduct the affected eye because it supplies the lateral rectus, so it can't look out, it can only look in. And some of the differentials of raised intracranial pressure are things like hydrocephalus. So that's an abnormal accumulation of cerebrospinal fluid in the brain. And that's caused by reduced absorption, which might be in things like infection or congenital conditions or normal pressure hydrocephalus, or reduced outflow of CSF. So that can also be congenital, like stenosis of the cerebral aqueduct or a Chiari malformation, or acquired things like an intraventricular bleed or a tumor or a cyst or something that's blocking the outflow of CSF. It can happen in pediatrics. I think it's a pediatric condition, hydrocephalus, and it can be picked up on ultrasound. So in kids, there's classic things like bulging of the fontanelles and sunsetting of the eyes. And adults get classic signs of raised intracranial pressure with hydrocephalus. Brain tumor and mets, as in this question, subdural hemorrhage, extradural hemorrhage, subarachnoid hemorrhage, or idiopathic intracranial hypertension can all cause raised intracranial pressure. That's just quickly a CT of hydrocephalus. So the key features of that would be loss of the sulci and the gyri, and some enlarged ventricles. And then those are the key features in children of hydrocephalus. So brain mets, in terms of the treatment of that. So you'd obviously want to discuss this lady with acute oncology if you diagnosed her with having brain mets. Something that's quite a good treatment in the acute phase that's often advised is dexamethasone, because it can reduce the swelling, and it can also help with symptoms like nausea and vomiting. Surgery, chemotherapy, and radiotherapy are also other options for managing brain tumors, brain mets, but that would be like kind of case by case. And you'd want to manage the complications. So you want to manage the nausea, you want to manage the seizures if they're having them, and you want to manage any speech and swallowing difficulties by referring to SALT. Okay, so question 6. So which of the following can be used to treat trigeminal neuralgia? So paracetamol, prednisolone, acetazolamide, carbamazepine, or tacrolimus. So I'll give people a little bit more time to answer. Okay. So you've done really well. Most of you went for D, and that is the correct answer. So paracetamol, go back. Paracetamol is not really an effective treatment for pain caused by trigeminal neuralgia because it's neuropathic pain. Prednisolone is also not a treatment for trigeminal neuralgia. It's not a swelling. It's like a cranial nerve palsy. Acetazolamide is a diuretic that's used to treat hydrocephalus, but isn't used in trigeminal neuralgia. Carbamazepine is an anticonvulsant, which are commonly used to treat this condition, and tacrolimus is an immunosuppressant, but trigeminal neuralgia is not an immunomediated condition, so we wouldn't use it for this. So it is a unilateral severe episodic facial pain in the trigeminal distribution. The pain's described as electric shock-like. It's recurrent and can be triggered by things like cold and eating. And even things like just air on the face can trigger it, like cold air blowing on the face. Risk factors are, so females are more likely to get this one. Older age, having MS is a risk factor, and having a family history. Trigeminal neuralgia can be primary, so the cause is vascular compression near the root of the nerve, or it can be secondary, which is compression by something like an acoustic neuroma, a meningioma, a cyst, or demyelination, as in MS. It's important in trigeminal neuralgia to always examine the patient's face and mouth, because you want to rule out any other cause of facial pain. And you also want to rule out any underlying cause that could be treated, things like an acoustic neuroma or a brain tumor or a cyst. So the red flag type things are a family history of MS or previous optic neuritis, because that might suggest that this is actually a presentation of MS. And then just going on to the treatment. So first line are things like anticonvulsants. So NICE CKS, the first line is carbamazepine and advises you to up titrate. You can use other anticonvulsants like lamotrigine. And then second line things are things like gabapentin and baclofen. There is surgical management options for trigeminal neuralgia. So something called microvascular decompression is used. So the compressive loop of vasculature, so like in this picture, the artery is compressing the vein. It's manually separated from the nerve, and then like a Teflon sponge is put in between the nerve and the artery to decompress the nerve, so remove the thing that's irritating the nerve. You can also do gamma knife surgery, which is ablative, so kind of destroys the nerve, or neurostimulation, but you'd refer to neuro if you weren't sure or there were any red flags or anything else. Okay, question 7. So there's your poll. 65-year-old woman presents to her GP and she has malaise and recent onset unilateral headache over her right temple. The patient reports struggling to get up from her chair the past few weeks. She's also recently ordered glasses online, and she's noticed some new blurriness in her vision. Past medical history is significant for hypertension, CKD3, and she smokes 20 cigarettes a day. Which of the following tests is most appropriate to request to diagnose this patient's condition? So A, ESR, B, ophthalmic slit lamp examination, C, vascular duplex ultrasound, D, CT angiography, or E, MR angiography. So this one has been a bit trickier. I think maybe the wording of the questions thrown some people off. So there you go. So most people have gone for A, and we can talk about each one in turn. So ESR is a really good indicator of inflammation, but it's not a specific blood test that would be most appropriate to request to diagnose this patient's condition. So we're thinking this patient has giant cell arteritis with a unilateral headache and symptoms like polymyalgia rheumatica, and she's got some visual signs as well. So the most appropriate test to diagnose her condition would be a vascular duplex ultrasound from this list. So ESR, good indicator of GCA, but it's not specific, and it can be raised in all sorts of inflammation. Ophthalmic slit lamp examination would be very important to ask for in this patient, given her visual symptoms, but it can't offer us a diagnosis. Vascular duplex ultrasound is the best option listed, and you're looking for things like a halo sign and stenosis. They're characteristic of GCA, and ultrasound is actually really highly specific for giant cell arteritis. So in some senses, it's superseding temporal artery biopsy as the main diagnosis of choice. It's non-invasive, there's no radiation, it's really cost effective. So that's one to bear in mind, as it might in future actually replace the biopsy. CT angiography is not a diagnostic test that we use in giant cell arteritis, and MR angiography can't actually visualize the temporal arteries. It doesn't have like the spatial resolution to see the temporal artery. I think there's something like high resolution MR angiography might have a place, but just your bog standard wouldn't be able to diagnose it. So yeah, so that's just pointing out that the question's asking you what test could diagnose this patient's condition. It's important to mention that no test could really diagnose, no test can offer like a definitive diagnosis for giant cell arteritis. Like no test is guaranteed to, which is similar to other types of vasculitis. So a temporal artery biopsy can offer you a definitive diagnosis if it's positive, but it can have skip lesions, so it's not guaranteed to diagnose it. Yeah, but like ultrasound is very good, TAB is very good, and then it's kind of based on the clinical picture. So if they've got a raised ESR, the clinical features, then you're kind of pretty sure that that's what they have. So giant cell arteritis is a sight-threatening large vessel vasculitis. That's symptoms of unilateral headache, scalp pain, jaw and tongue claudication, visual symptoms, so things like blurring, amaurosis fugax, which is temporary monocular blindness, diplopia, so double vision, and vision loss. Systemic symptoms are also really common in giant cell arteritis, so things like malaise, weight loss, fevers, night sweats, and symptoms of polymyalgia rheumatica, so that kind of proximal weakness. The signs are like an abnormal temporal artery, visual field defects, a pale swollen optic disc, which would be suggestive of like ischemia, retinal changes, cranial nerve palsy, and cardiovascular disease is more common in giant cell arteritis. So your main risk factors are being over 50, female, having PMR, and being Northern European. And to investigate it, as I said, we do ESR or CRP, we do the ultrasound scan, a temporal artery biopsy, a PET scan if we're worried about large vessel involvement, so like thoracic or aortic root involvement, and an ophthalmic assessment if they've got visual symptoms. So treating it, if they've got no visual change, you'd start someone on oral prednisolone, and that would be for 4 weeks, and then you taper down. But if they had visual symptoms, then you'd want to give them a higher dose of oral prednisolone, and you'd want them to have a same-day ophthalmology referral, or you'd refer them for consideration of IV methylpred for like 1 to 3 days, and then a course of oral prednisolone. The issues come if someone can't tolerate steroids, or steroids are contraindicated, or they're unable to taper. So every time you try and taper the steroids, they get a flare of their giant cell arteritis. And then you'd need to refer them to a specialist, and you'd need to think about like immunosuppressants, so things like tocilizumab or methotrexate can be used. It's important to remember for exam questions, definitely, and for your practice, steroid complications. So especially in older people who are going to be presenting with giant cell arteritis more commonly, osteoporosis. So you want to prevent that by co-prescribing a bisphosphonate, vitamin D and calcium supplements. High sugars. So if someone's got type 1 or 2 diabetes, you want to be monitoring their sugars more closely and maybe giving them some dietary advice. And GI bleed can happen with steroids, so giving them a PPI at the same time is always sensible. Mood changes, insomnia, weight gain, immunosuppression, and a Cushingoid appearance. And when you're weaning off as well, adrenal cortex suppression, they're all other side effects that can come along with steroids. So watch out for those. Question 8. So pop your poll up. Which of the following statements regarding idiopathic intracranial hypertension is correct? CT head may reveal hydrocephalus. Many patients with idiopathic intracranial hypertension have an isolated oculomotor nerve palsy. 50% of patients with idiopathic intracranial hypertension report pulsatile tinnitus. Normal pressure hydrocephalus and IIH are synonymous, or male sex as a strong risk factor. So the answer to this one is C, 50% of them report pulsatile tinnitus. So it looks like most of you, 37% of you got that right, which is pretty good. So we go through that now. So IIH, CT head is done to rule out any treatable abnormality, but hydrocephalus wouldn't be seen in IIH. Normally the CT head in IIH is normal. An isolated cranial nerve 3 palsy is associated with aneurysm. A cranial nerve 6 palsy can be seen in about 20% of people with IIH. Pulsatile tinnitus is a very common symptom. Normal pressure hydrocephalus is a form of hydrocephalus, so it's not the same as IIH. And actually females, obesity and smoking are risk factors for this condition. So running through, headache's a common symptom. Its main feature really is increased intracranial pressure in an alert and oriented patient. And they often get visual symptoms, so like blurring and diplopia. And when you examine them on fundoscopy, you'll find papilledema. We've talked about the risk factors. Investigations could be like a CT head or an MRI. And then what's really key is doing an LP, because you're looking for a raised opening pressure. So management is weight loss, serial LPs, acetazolamide, topiramate, furosemide, or surgical intervention. And normal pressure hydrocephalus isn't the same as IIH. It's got the clinical features of hydrocephalus, but no raised CSF pressure. And its presenting symptoms are like a cognitive impairment, gait apraxia, incontinence, and it's generally associated with people who are over 65 with vascular disease. So question 9 now. Just share the poll. A 46-year-old woman presents to ED with a sudden disabling headache. She reports intermittent severe headaches over the last week, which self-resolved. The pain is at the back of her head and she has not suffered any trauma. She's vomited 3 times this morning. She has a past medical history of PCOS and hypertension. Smokes 20 a day. Her BMI is 35. On examination, the patient has some neck stiffness on flexion, but the neuro exam is grossly normal. Obs are basically fine. She's just got a bit of a raised blood pressure there and a raised respiratory rate. So what's the most likely diagnosis? You've all gone for subarachnoid hemorrhage, which is correct. Well done. So A, she's got no infective signs. She's afebrile. She's not been unwell, so it's not meningitis. About migraine, so it was a sudden onset headache and it was at the back of her head, so it's occipital, so it's not a unilateral headache. C is possible, but it would be atypical for that. So she's not got any neck pain, she's not got any posterior circulatory stroke symptoms, so things like ataxia, diplopia, dysdiadochokinesia, those kind of things would be associated with C. D, that is what she has. She's a smoker with high blood pressure. I'm pretty sure I put in the main question, but it hasn't carried over to this slide, that she had Ehlers-Danlos syndrome, which is a connective tissue disorder which would predispose her to having a subarachnoid hemorrhage or an aneurysm and a bleed. She's got this preceding history of severe headaches, and she has occipital pain, so that's the correct answer. So the symptoms and signs of this: thunderclaps, sudden onset headache with meningism, so photophobia, neck stiffness, focal neurological deficits, a collapse, a reduced level of consciousness, a cranial nerve palsy, which there's a picture of there, and diplopia and ptosis, cardiac arrest. The cranial nerve palsy, if you have like an isolated oculomotor nerve palsy, it kind of locates the pathology to the subarachnoid space, and it's a sign of an enlarging aneurysm. And the key thing is it pupil sparing or pupil involved? So the parasympathetic fibers that control your pupils are superficial in the nerve. So if it's a compressive lesion like an aneurysm, those superficial fibers are going to be more affected. So you lose the pupil light reflex. So you get a fixed and dilated pupil if it's a compressive lesion like an aneurysm. Whereas if it's pupil sparing, it's probably a vascular lesion because they affect the inner fibers of the nerve preferentially. So it spares the pupil. So things like ischemia or diabetes, when people are presenting with a cranial nerve 3 palsy, if their pupil light reflex is intact, it's probably a vascular lesion, not a compressive lesion. So common risk factors are kind of self-explanatory, but a key one is things like autosomal polycystic kidney disease, Marfan's and Ehlers-Danlos. So that's what it looks like on CT. It's like a hyperdense material in the subarachnoid space, commonly around the circle of Willis. So question 10. A 27-year-old man with a sudden severe onset headache describes the pain as 10 out of 10. Prior to the headache, the patient experienced sudden partial visual loss, which is now resolved. He's oriented to time, place, and person. Neuro exam is normal. He's fit and well normally. CT head is done 5 hours after the onset of the headache, which is reported as normal. What's the most appropriate next step for managing this man? So A, repeat the CT head at 12 hours, immediately perform a lumbar puncture now, wait more than 12 hours, and then perform an LP, request a CT angio, or treat as a migraine and monitor for 24 hours. Okay, so this is quite a hard question. I'll just share. So everyone's gone for C. The answer is actually E for this guy. It's a bit like of a grey area, so I'll go over it quickly. So I'm just going to skip to the slide that shows the nice guidelines for subarachnoid hemorrhage. So the first diagnostic investigation is a CT head if you're suspecting that this guy's had a subarach. If the CT head is done within 6 hours of symptom onset, and for this guy it was done within 5 hours, then, and if it's negative, then you've got to think about a different diagnosis. You don't have to. There's a grey area. So you could do an LP if you still thought clinically it was subarach, but his CT head is normal, and that's more than 99% sensitive if done within 6 hours for subarachnoid hemorrhage. If you have a negative CT head more than 6 hours after the symptom onset, then you'd consider a lumbar puncture, but it would need to be done more than 12 hours after symptom onset. And if you had a positive CT head, then you know it's a subarach. So I'll just go back to the question. So there's no need to repeat his CT because it gets less sensitive in the time after headache onset. Immediately performing a lumbar puncture is wrong because it would need to be done at least 12 hours after onset. C is not as per the NICE guidelines, as performing a CT head within 6 hours is more than 99% sensitive, and he's got no real concerning signs. So he's 27, so he's not in like the risk factor age range. And prior to the headache, he had this visual loss, which could be a migraine aura, and it's now resolved. He's totally oriented. His neuro exam is normal, and he's normally fit and well. He doesn't have any risk factors for this, and the STEM doesn't mention any history of trauma. So it would be safe, if obviously in discussion with a senior, to make the decision to treat this as a migraine and monitor him for 24 hours, given that his CT head was negative. So in the papers that I looked at when writing this question, because I was quite careful with it, the people that they've investigated and did the LPs for, and after a negative 6 hour CT head, they only missed something like 1 or 2 subarachnoid hemorrhages out of like a few thousand. And they were really rare types of subarachnoid hemorrhages, and of the people that they would have missed, none of them had any adverse outcomes. So I think it's interesting that they've changed the NICE guidelines now. Just going through subarachnoid hemorrhage investigation. So you do a plain CT head, 99% sensitive and specific within 6 hours. If it's performed after 6 hours, it's much less reliable. So you do an LP after 12 hours from onset. And if it has xanthochromia, so that's the one on the right, then there's hemoglobin and bilirubin in the CSF. And so you'd be worried about subarach there. And this just goes through it all over again. So we've talked about it pretty much all the way through. If we've diagnosed subarachnoid hemorrhage, then we want to offer them a CT angio because we want to find the aneurysm. And then once we've found the aneurysm, then we want to do something about it. So we want to talk to a neurosurgeon. I would suggest you guys look at this flow diagram in more detail in your own time, because it's a really useful tool to think about how we manage it. In terms of treating it, you want to do an A2E assessment because it's obviously a medical emergency, and manage the airway if their GCS is low. You want to do neuroobs, give them pain relief and antiemetics. That's because you want to prevent like the Valsalva while they're vomiting. So you don't want to increase any of the intracranial pressure by them vomiting. So give them lots of antiemetics. You want to control their blood pressure. And you want to give them nimodipine for 21 days. That prevents cerebral ischemia. Doing a salt assessment and fluid balance monitoring would also be good management. Surgical wise, if they've got hydrocephalus from it, you give them a drain, like a shunt drain. And you also want to either coil the aneurysm or clip the aneurysm. So when they coil it, they're putting like platinum coils inside it to induce embolization. And if they clip it, then they do a craniotomy and they clip the aneurysm at the neck. So question 11. A 33-year-old man is in an RTA. On arrival to ED, he is assessed and suspected to have multiple pelvic fractures and a broken collarbone. On the way to X-ray, he complains of headache and then goes on to have a tonic-clonic seizure. His CT is shown on the right. Which blood vessel has most likely been damaged? The bridging veins, the anterior communicating artery, the middle cerebral artery, the middle meningeal artery, or the basilar artery? So the answer to this question is middle meningeal. So most of you got that right. So well done. That's 65% of you. So we'll just go through the different ones. So bridging veins are most commonly damaged in subdural hemorrhage. And I don't know why, but I always remember it as in like a submarine would go under a bridge. I just had a massive mental block with which one was which. So a submarine goes under a bridge. So subdural is bridging veins. And then anterior communicating is the most common site of an aneurysm. Middle cerebral artery is commonly affected in ischemic stroke. Middle meningeal is correct here. And the basilar artery is a posterior vessel that supplies the brainstem. So his risk factors here, he's had a massive trauma. He's got a headache and then he has a seizure. So that's why I've done a CT head. And you can see in this guy's CT head that he's actually got an overlying skull fracture there and some hematoma under his skin and over his skull, as well as the hematoma in the brain. So extradural hemorrhages are biconvex on the CT head. So you remember it as in extradural is egg shaped, so extradural. Limited by the cranial sutures, so often an overlying skull fracture. Classically, people get this like lucid interval and then decline. It's not diagnostic. It can happen in other types of intracranial bleed, but for some reason it's like super associated with extradural hemorrhage. And then subdural hemorrhages look like this on a CT. So they're a crescent-shaped hyperdensity. And they're tearing of the bridging veins. So they're traumatic and non-traumatic. So non-traumatic would be things like a ruptured aneurysm or a brain tumor. The risk factors for these are generally being elderly, being on anticoagulants, drinking a lot, and liver dysfunction. The features are more a classical slow progressive history, like fluctuating kind of confusion, or like lots of unwitnessed falls in old people would make you worry about subdural. But generally the features are similar to extradural hemorrhage. in terms of investigating them, sorry, you'd obviously do a CT head and some bloods. You'd investigate for other trauma, like with a CT cap if it was indicated. Managing them, you'd want to do like manage the C-spine if they're a trauma patient, and then do A2E. You want to reverse their anticoagulants and do classic neuroprotective things. So maintain normal oxygen levels, normal blood pressure, normal temperature, sedate them, monitor their intracranial pressure if it's serious. And then treat the complications. So if you're going to manage these surgically, lots of them just resorb themselves, but if you're going to manage it, conservatively, lots of them just resorb themselves, so it's time, and then surgically is decompressive surgery. Anticoagulant reversal. So I did a PSA session on Tuesday and we talked a little bit about this, and some people wanted like a little summary of what the reversal agent is for each blood thinner. So heparin's reversal agent is protamine sulfate, warfarin's is vitamin K, so phytomenadione or prothrombin complex concentrate. Dabigatran is idrucizumab, and apixaban or rivaroxaban is called adexanet alpha. Okay, so question 12. There you go. A 39-year-old man presents to ED with a 2-week history of flu-like symptoms. On examination, the patient has a low-grade fever, mild photophobia and neck stiffness. He's oriented to time, place and person. Neuroexam is normal with no motor or sensory deficits and no evidence of raised intracranial pressure. He has a past medical history of rheumatoid arthritis controlled on methotrexate. The decision is made to perform an LP. So he's got a slightly raised opening pressure, a normal glucose, a low protein, and a slightly raised white cell count, and it's a colourless sample. So you've all got it right, really. The answer was D, viral meningitis. So we can go on to talk about why. So an aseptic meningitis, well, there's clearly white cells in this sample and he had a raised opening pressure. It's just the white cells, so it's not aseptic. Herpes simplex encephalitis, so the stem doesn't really describe him having an altered mental state. Bacterial, so the white cell count isn't really high enough. The opening pressure is high, but it could be higher in bacterial. The protein is normally high in bacterial, and the appearance was colourless, but in bacterial it would be turbid. And similar for fungal as well. We're just going to go straight on to question 13 because they're both relating to meningitis, so then we can talk about it all at the same time. So I'll just do the poll for question 13. So a 52-year-old lady is admitted to hospital with vomiting and headaches. Her temperature is 38.2. She has no significant past medical history and no known drug allergies. Blood tests reveal a marked inflammatory response. An LP is performed to test for meningitis. The CSF stain is shown on the right. Given the likely causative organism, which of the following antimicrobials would best treat the infection? So most of you got this one right as well. Most of you have gone for A, which is the right answer. So IV cefotaxime and IV amoxicillin is correct. IM benpen you could give in the community if you were worried about someone having meningitis, but she's already been admitted to hospital, so we can give her things IV. IM ceftriaxone is kind of, I think it's a treatment for gonorrhea. A cephalosporin is appropriate, but you probably give it IV. And IV amphotericin and fluconazole, they're the fungal treatment for meningitis. And oral Cipro is the treatment that you give for contact prophylaxis. Just looking at the gram stain, because it's purple, we know it's gram positive and it's a diplococci, so there's like paired circular shaped organisms. So it's probably strep pneumoniae because that's a really common cause of meningitis. And you'd want to cover that with IV antibiotics. So meningitis is obviously infection of the meninges. It can be bacterial. So this table is really good. It's like a summary of like the causes by age. So it can be Neisseria meningitidis, strep pneumoniae, H influenza, group B strep is common in babies and children, E. coli and listeria. So that's common in either the very young or the very old, the immunosuppressed and the pregnant. And then there's TB as well. There's lots of viral causes and fungal causes, but we won't go through all of them. In terms of the features, so it's the classic fever, headache, stiff neck, photophobia. Opisthotonus is like abnormal posturing due to like spastic contraction of the back and neck muscles. So you're kind of like arched from your heels to your neck. Alter GCS, septic shock, meningococcal, non-blanching purpuric rash. So Koenig's and Brzezinski's are there. They can't rule out meningitis just because they're not present, but they're a good sign to show that someone's got meningism. And then just the standard investigations. So bloods, you want to definitely look at their platelets and clotting, because you're going to be doing an LP on these people. So you want to make sure they're not going to bleed. A chest x-ray, a CT head, and obviously a lumbar puncture. So CSF interpretation, that's just like a summary table that you can have to look at in your own time. But classically in bacterial, you'd have like a raised opening pressure, a raised protein, and a normal or low glucose. Whereas in viral, you'd have a normal or slightly raised opening pressure, a slightly elevated white cell, a normal glucose, and a normal or raised protein. Or sorry, that should say normal or reduced protein in that table. I'll change it before we send these slides out. So the management in the community is IM benpen. And then antimicrobials are things like the antibiotics we've talked about. You might want to add on amoxicillin if the patient's over 50, because you want to cover for things like listeria. Acyclovir you give if you've got concern about HSV encephalitis. Amphotericin B is the fungal one, but you'd always discuss that with micro because it's a bit rogue. IV Dex you can give to kind of prevent the neurological sequelae with meningitis, and you definitely want to do that if someone had got strep pneumoniae. And then the contact prophylaxis, as I said, is oral Cipro, and it's a notifiable disease, so you'd want to tell Public Health England that someone had it. Okay, so we're nearly there. Thanks for sticking with me. We're going on to question 14 now. So an 18-year-old man is admitted with headache and associated photophobia. The patient has a widespread non-blanching petechial rash and a temperature of 39. He is diagnosed with suspected meningococcal sepsis and promptly started on IV antibiotics and fluids. Despite this, the patient rapidly deteriorates and is transferred to ICU for ventilatory and circulatory support. Bloods reveal raised white cells, very high CRP, very low platelets, prolonged clotting, a positive D-dimer, and low fibrinogen. So you're thinking that this man might have DIC. His sodium's low and his potassium's a bit high. His creatinine's raised and he's got an AKI. 24 hours later, despite treatment, the patient sadly dies. Post-mortem reveals a bilateral adrenal gland hemorrhages. What is the name of the syndrome classically associated with this presentation? So lots of you have got this right. Really well done. It's very rogue. So the answer is B, Waterhouse-Friderichsen syndrome. So A, Lennox-Gastaut is a childhood epilepsy syndrome. You can work through this one mainly by ruling the other ones out if you know what they are. So Lennox-Gastaut is a childhood epilepsy syndrome. Dandy-Walker is a syndrome of congenital hydrocephalus, which causes reduced CSF absorption. Ramsay-Hunt is like shingles outbreak to the facial nerve, and Wallenberg syndrome is damage to the lateral medulla, which causes things like checkerboard sensory loss, Horner's, diplopia, dysarthria, and dizziness. So complications of meningitis, that's what this question is really asking about. So immediate complications, things like severe sepsis, multi-organ failure, seizures, cerebral edema, and death. Long-term complications are things like deafness, seizure disorder, so developing epilepsy, getting a focal neurodeficit, cognitive impairment, or primary adrenal insufficiency. So that's what this question is asking about. So Waterhouse-Friderichsen syndrome, that's what you can see on the CT scan here. I don't know if you can see my mouse, but I'll just try and orient you. So the patient's lying on a bed, and then the white bit there, that's his vertebrae. And then he's got like some subcut fat and his ribs around that. The bits to the left and right of the vertebrae, the big kind of grayish sacs, they're the bilateral adrenal gland hemorrhages. So they should be much, much smaller than that. Your adrenal glands are really small. So it's caused by severe bacterial infection, classically Neisseria meningitis, and it results in an adrenal crisis. So the adrenal glands stop making the hormones, aldosterone and cortisol. You might get things like sudden back pain, abdomen pain or leg pain. You might vomit, have diarrhea, septic shock. And classically in adrenal crisis, you have low sodium and high potassium. So you treat it with IV hydrocortisone and you'd manage their infection, but this would like definitely be treated in ICU. And you'd offer like blood pressure support and ventilatory support if they needed it. Okay. Last question, we're nearly there. I'll just get the poll up. So question 15. 67-year-old man is seen on the medical take. The patient is drowsy but rousable and is not answering your questions appropriately. His wife explains that he's been complaining of a sore throat and headache for over a week. However, over the last 24 hours have become agitated and claimed not to recognise her. She rang an ambulance after he had a seizure at home, which self-terminated. His past medical history has BPH and type 2 diabetes. His OBS and blood results are shown below. So he's got a raised rest rate, slightly low saturations, a raised heart rate, a normal blood pressure and a high temperature. His HB is normal. He's got raised white cells and CRP and platelets. What would the most appropriate next step be in managing this patient? So you've all gone for B. Well, most of you have, which is good because that's right. So A, arranging a CT head and performing a lumbar puncture. So before anything else, this man needs antibiotics because we're suspecting a serious like meningoencephalitic infection. And any delay in giving him antibiotics would increase his mortality. So B is correct. We want to give him cover for bacterial meningitis and we want to give him cover for viral encephalitis. The second answer is wrong because he's not got any viral cover in it. C, sorry, is wrong because it hasn't got any viral cover in it. D is wrong because this isn't a mental health disorder. It's altered mental state secondary to infection. And E, so arranging an EEG and loading him with Keppra might treat his seizures, but it's not going to treat the cause of them. So he really just needs antibiotics as soon as possible. Okay, so encephalitis is inflammation and infection of the brain parenchyma. The symptoms are generally like more cognitive than meningitis, which is how you distinguish them. So there's this classic triad of fever, headache, and altered mental state. You get things like vomiting, seizures, behavioural change, so psychosis, change in your affect. You might get memory problems. HSV affects classically like your temporal lobe, and so some people say they get this rotten egg smell. I don't know if that would come up in an MCQ. So the causes are infectious, so viral, bacterial, fungal, parasitic. HSV is the cause in more than 90% of adults. There are non-infectious causes as well, so post-infection is usually the case if children have it, and it's like demyelination of the central nervous system, because after the infection the antibiotics attack the myelin. Autoimmune encephalitis, so you might have done a past med question on NMDA encephalitis. So you can get like psychiatric manifestations like agitation, delusion, hallucinations, memory deficit, sleep deficit, autonomic instability, and then paraneoplastic, so like limbic encephalitis and things like that. You'd investigate it with a chest x-ray because you're doing a septic screen, CT and MRI head, LP, EEG, serological testing if you were suspecting an autoimmune cause. Empirical management, so antimicrobials and an antiviral, and then you can direct them to the cause once you know it. And non-infectious causes you would treat with immunosuppressants. Okay, so in summary, we've covered like so many causes of headaches. We've gone over like all the primary causes, tension, migraine, and then there's the trigeminal autonomic cephalgias, which really is just cluster headaches and then some other rogue ones. And then there's loads and loads of differentials for secondary headaches. So I've tried to kind of summarize them in a couple of tables. So those are like the distinguishing features of migraine, cluster, and tension headaches that we've gone over today, and their different treatments. And then the secondary headache differentials, I've tried to split up into categories. So infection, blood vessel related things, raised intracranial pressure related things, low intracranial pressure related things, toxins and other causes. Don't forget with headaches that preeclampsia causes headaches, and that's where like crossover of neuro and obs and gynae might come together in one question. So make sure you look over some of your like specialty notes from 4th year as well. I'd really appreciate if you could all fill in the feedback. Well done for making it this far. I know we've run over a bit. I don't know how the questions have been, you guys, or if there are any that are still left over. I'll have a quick look now.
Sorry, I'm just slowly making my way through them.
It's fine. So
I
someone's
think some of the questions relate to some of your questions on the slides, but I can't remember which questions they relate to, so I can't answer them.
I'll try and
Like, there's a question, why can't it be a stroke? And I don't remember which question that is.
I
can't-
think that one was related to the giant cell arteritis question,
Oh, right.
but I again don't remember the question. Yeah.
Oh, sorry, I think I've just shut the. Am I still sharing my screen? Am I not?
No.
Can you? Okay, I'll try again. Can you see it now? Try and go back to the GCA one. I don't know what it is either. If you want to answer to that question, maybe pop some clarification in the chat. Why did she have preceding intermittent headaches? Yeah, that is common in subarachnoid hemorrhage. Lots of people do get that. But it looks like you guys have smashed it with the questions. Well done. Thanks for answering all of those. Someone's just asked, what do you do for investigations if it's been more than 6 hours for subarachnoid hemorrhage? So you'd still do a CT head because it could still be positive. So you'd always still do a CT head. That's the first line investigation. If it's been more than 6 hours though, and it's negative, you can't trust that they definitely haven't had a subarach. So then you'd wait 12 hours and do an LP. I'll go back to the QR code for the feedback. Oh. There you go. I can't see those more questions coming through. So if everyone's finished asking everything, then we can maybe call it a day there. But thanks so much for coming, guys, and well done for sticking through to the end. Would really appreciate if you filled the feedback out, and then you can get all these slides and my nice tables. All right.
Just typing one last answer, I think.